my talk is about deep anterior lamellar keratoplasty. That is still a surgery not used enough, because a lot of surgery are still doing PK for stromal disease. This is not correct, because with the PK we can have a lot of intraop complication, as you can see here. Look this case with the severe choroidal hemorrhage and rejection and graft failure. It's something not too rare. Sometimes we lose our graft, and when we go to make a regraft, the survival of regraft is much worse. If we look at the survival, you can see that PK has a survival of 82% after 10 years. DALK is 99.3 after 10 years. And even DSEC has a better survival of PK. And the MEC and the living-related conjunctival allograft. So the PK is one of the worst surgery we can do for stromal disease. Sorry if I say this. I know that a lot of surgeons are still using PK, but this is something that is wrong. If we look at the regraft here, you can see that the survival of a regraft for PK is 53% after 5 years. And when we go to the third regraft, the rejection is more or less 80%. So that's the reason that we cannot observe anymore people blind for multiple grafts. So we published this paper already more or less 10 years ago, no, 9 years ago, and the survival was very high after 10 years DALK graft survival. In 806 DALK, 711 patients between 2000 and 2009. Exclusion criteria was follow-up less than 6 months and lost from follow-up visit. So the indication of DALK was keratoconus 70%, but herpes scar and other opacities are 25%, especially herpes. Herpes is something that we need to do DALK, because in the herpes infection, we don't have only proliferation of a virus. We even have a immunological rejection, and we need to do a surgery that has to be much more quiet and elegant, not stimulating the immunology. The endothelial cell loss, it's amazing. You can lose 9-10% of endothelium in the first 6 months post-op. Then the endothelium remains stable lifetime. With PK, endothelium decrease year by year. What about rejection? Rejection is very rare in DALK. You can have an early rejection, that is an epithelial rejection, that you can fix with just with some steroid drugs. Or you can have a subepithelial rejection that is related with an immunological reaction, often is confused with adenovirus keratitis, but is a rejection. You can make the diagnosis because you can see that the lesions are only in the graft, not outside of the graft. Well, I just want to show you I don't want to bother you so much with the theory. Then we move to the exhibition of DALK. Well, let me say that graft survival is 98% after 10 years. The average goes, it's 99.3 with the 54 months follow up, and graft failure is only 0.6% and is always an early failure and is related to the ocular surface defense that are not very good because nerves were cut during surgery. But this is for PK as well, because when you cut the nerve, the tissue is not able to understand that is in trouble and you can lose the graft. And survival graft after 2 years is not time dependent anymore. You will not lose any graft after 2 years. So in 2010, my group published this paper dividing DALK in DDALK and PDDALK. What it means that the original DALK surgery was done with a manual dissection, but you will never expose the decimate. It's just after 2001 when we started to use visco dissection or big bubble that we were able to reach the decimate and have really a very deep dissection and cleaving off the deepest plane. Well, this is very important for you. Don't forget that if you do manual dissection, you you have to go deeper and deeper, at least until less than 80 micron residual bed. Because if the stromectomy is not deep enough, the patients will not have a good vision. It was this aspect was already described from José Baraquer in sorry, I have a bit of flu. It was already described from José Baraquer in 1971. The difference of visual recovery between DDALK and PDDALK is just that with the DDALK, the recovery is faster. But after 30 months, the recovery can be more or less the same. The problem of DALK is learning curve because it looks a difficult surgery, but it isn't. Because if you usually do PK, you can ever convert to PK if you are in trouble. So you should start trying DALK and convert to PK if you will be in trouble. Let me say that now we already published paper and presented talks at meeting. The title was "All the Rupture Can Be Fixed." It means that you has to be an expert surgeon. So there are many surgical techniques described in the literature, but I believe that the most important are peeling off. It was described from Malbrand in 1972. This is an amazing procedure. In other words, if you go in the periphery and you dissect the periphery very deep, sorry, at the end you can peel off the stroma. I show you the surgery here. See, we are in the periphery now. We are going deeper and deeper, and at the end we can peel off the stroma. If you make this surgery, that means that your DALK is very good. because you can peel the stroma off when you are deep enough at 30 micron from the decimal. So if you find this surgical pattern, you can be sure that your surgery is okay. This is the OCT after peeling off. See, it's 26 micron. Hydrodissection was described by Sujita in 1997. What he suggested? He suggested push some BSS in the stroma and you will have some advantages. First of all, you can see all the stroma because it's with fluid inside. So you know when you are deep. And even the dissection of lamella, it's much easier because all the lamella are with fluid and the spatula moves much better. See? This is Sujita technique, but it's a DALK, original DALK technique, before then big bubble, before then visco dissection. Subota in 1998 suggested a technique that I don't like. I don't like because the tissue is too tight. He said, don't put air, don't put fluid, don't put anything, because you will see better. Well, I do not agree, because look here. This was a regular maneuver. But because the tissue is too tight, it's easy to break. So I don't suggest you to do this kind of surgery. The tissue is very tight. I suggest you make wet your surgical plane every time. Finally, in 2000, Melles found a technique that can cleave off the deepest plane to the stroma using something viscoelastic. This was my first visco dissection. It was 2001. You see, you go deeper and deeper, and then you push viscoelastic inside. There is some air in anterior chamber, so you go deeper and deeper until you see that a visco bubble can be created by visco. And the specific sign is a ring that now you are seeing. You see here, this ring is the periphery of our visco bubble, and this now can grow and reach the periphery, pushing visco. And as you can see here, now we have a very good visco bubble, and surgery become easy because you have Deshmet back and stroma up. See? This is so old video, so at that time I was cutting the stroma in the periphery. Now I prefer to cut in the center for many reasons. So needle big bubble is the technique that conquered all the world. Because easy, because clear, and there are many aspects that you can follow easily, as you can see here. Anvar suggested to use a needle and pushing air in the stroma. You can dissect stroma from the deepest plane, and here you can remove more or less all the stroma. So at the end of the first decade of this millennium, we suggested to not use any more needle, because now we know that to have a big bubble, we have to push the air very deep. And when we are with needle, we are always afraid that we are too deep and we can perforate. So we thought, why don't we move to a cannula? Because with the cannula, you won't perforate. And the surgical maneuvers are absolutely more safe. So this is the cannula that we proposed. It's a cannula with the bottom all down, 27 gauge. And this is the spatula that make a tunnel. And then we can put the cannula. Here is the surgeon. So I first refine 400 micron, and then I go inside with cannula, with spatula, and then with cannula, and this is the bubble. It was published in 2009, and the number of big bubble grew from 70% to 92%. In the same period, we had two other cannulas, very similar, a little bit different. One for my friend Donald Tan, and another one for my great friend Raish Fogler. Now you can find many other cannulas. Everybody invented the cannula, typical of the man. Well, my daughter Enrica published this paper comparing the results between cannula DALK versus needle DALK. And you can see that the D-DALK, that means the DALK dissecting very deep the plane, it is 78% with the needle, and it grows to 94%, and the ruptures goes to from 6.5 to 2.5, because if you have a larger number of big bubbles, surgery becomes easier and is less frequent that you can perforate. And conversion rate was 0 because we fixed the rupture. So the advantages of cannula is increase the number of DDAL, faster recovery of vision, surgical time is reduced, less surgeon stress, and reducing attachment member ruptures. So what can we do if big bubble fail? Because we saw that was 72% and 92%. So what we have to do when big bubble fail? So in this case, I suggest to move to visco dissection, going deeper, and then with the visco, you can create a visco bubble. So in this way, you are reaching the same result, combining first failure of air and then a success with visco. So everything changed in 2013 when Arminder Dua published this paper speaking about a new layer that is very deep and is not stroma. And he described the big bubble type 1 and big bubble type 2. You should know this because now we know that with big bubble type 1 and big bubble type 2, our behavior has to be different because big bubble type 1 is much more resistant. Big bubble type 2 is very weak and very easy to break. So the big bubble type 1, you can see here, is a bubble that starts from the center and goes to the periphery, has a white edge, it doesn't go over than 8.5 millimeter, and popping pressure it's a bit higher because some stroma remain attached to the descent. And Minder said, this is not stroma, this is a new layer and has some characteristic. It's only big bubble type 2 that really cleaves off decimet from the stroma. And you can see here. So the big bubble starts from the periphery and goes in the center and is much more larger. And there is no stroma attached to the decimet. So big bubble type 2 really cleaves off decimet from the stroma. But in this way, the decimet is really very weak. It's just that you can touch the decimet, it will break. So in other words, DALK surgeon doesn't want big bubble type 2. They are trying to have big bubble type 1, not type 2. And this is big bubble type 3 that is a combination between big bubble type 1 and big bubble type 2. So the problem is that the acronyms that we suggested in 2010 in PD DALK and D DALK can be still used. It doesn't make sense because if we look at layer by layer, we can see that we are deep, but we didn't cleave. We just are having manual dissection. So this is a PD DALK, okay? If we do hydrodissection, as you saw, is a PD DALK as well, because we are not cleaving off decimet from the stroma. And peeling off is still a PD DALK, because even here we are peeling the stroma off, but we are not dissecting the stroma from the decimet using something. Okay, so if we go to big bubble type 1, we know that we are dissecting the deepest plane from the stroma. And we call it in the origin D DALK, that means decimetic DALK. So we were used to say that big bubble type 1 is a D DALK, as viscobubble or aviscobubble. But only big bubble type 2 really cleaves off decimet from the stroma. So at the end, we cannot use anymore this terminology because it's really in contrast with the histology. Because if you say D DALK, that means that we reached the decimet. But now we know that in big bubble type 1, in the viscodissection, some stroma remain attached to the decimet. So that's the reason that the decimetic DALK cannot be big bubble type 1 that goes up. And even viscobubble and the air viscobubble. But this is a worse problem because we know that PD DALK is a manual dissection. This technique are dissecting technique that are very deep. So we just published past month a paper where we suggesting a new terminology that is deep anterior lamellar keratoplasty, the original DALK, for the traditional technique, layer by layer, peeling off, and hydrodissection. but we suggested to use subtotal anterior lamellar keratoplasty for big bubble type 1, for visco dissection, and for air visco bubble, because we removed almost all the stroma. Not all, but almost all. And we suggest to use TALK, total anterior lamellar keratoplasty, for big bubble type 2, because we really cleaved off the Deshmet from the stroma. This is the nomenclature we suggest now to be in agree with histology. So PD DALK and D DALK are not used anymore. And now, after this paper, we are using DALK for the original traditional technique of DALK. We are using STALK for big bubble and visco dissection, and we are using TALK for big bubble type 2. So I just show you the standard technique today, and then I will show you the demonstration. So which is our standard technique today? We want to start a big bubble type 1, because we know that the results are great and the possibility to break the Deshmet is rare, and the results are very good. And we try cannula big bubble in the beginning. Let me explain you step by step the technique. So I like to refine the tissue 400 micron, and then look the spatula. At some point it goes fast. Here. You want to see again? Look at the spatula. When it goes inside, at some point it goes fast. You see? That means that you are deep enough. Because this deepest plane, it's the lamella are less strong than the surface.
Thank you for attending today's exhibit.
And the spatula goes fast, and you will feel in your fingers that the spatula moves very well.
Starting now in the exhibit hall.
And you want to be here with the spatula, very close to the decimal. And here you can put the cannula and push the air, and you can separate the deepest plane from the stroma. Bubble test is very important to be sure that you got the bubble, because sometimes it's not so clear that you got the big bubble. If you put some air in anterior chamber, you can see that the air remains in the periphery, because the shape of the decimate make the bubble in anterior chamber in the periphery. And this is the schema. See? The bubble remain here because the shape of the decimate. So the original technique from Ambar was this breve slash that I don't like, I'm not doing anymore, because I believe it's danger. So now we prefer to go inside in the bubble without lose the bubble. You see the knife goes inside. You can lose some small bubble here, but the big bubble remain. So now you have a big bubble connected with outside. And this is very important, because in this condition, you can go inside to the bubble with the cannula, and you can exchange the air with visco. And this makes the stromectomy much easier, because the visco make the Deshmet bake, and you can cut easier the stroma. And you can exchange bubble air with visco bubble, and then you can cut. Look, this is the video. So I went inside, I didn't lose the big bubble, and now air in the bubble. I'm sorry, visco in the bubble, and now you can cut the stroma and remove the stroma. That's the preferred technique we want because it's fast, very good result, and easier. But sometimes you don't have any big bubble. And this is not related only to how deep you are. There is a paper that described in vitro that the adhesion of decimate to the stroma is different case by case. And that's the reason that if big bubble fail, you should use visco because the energy of visco is much higher than bubble, the air, and can detach a tissue that cannot be detached from air. And now we know this, even preparing sorry, tissue for DMEC. We are not preparing tissue for DMEC in youngest people. We want people that are at least 50, 55 years because the adhesion of decimate to the stroma is less. And that's the reason that big bubble doesn't occur every time. So, as you can see here, bubble test is negative. We put a bubble air in anterior chamber, and the air doesn't remain in the periphery, went inside. So that means that we didn't have any big bubble. So what can we do in this case? I try another tunnel, and then I try visco dissection. And here is air visco bubble dissecting stroma from the deepest plane. Okay? So if B bubble fail, I move to air visco bubble. But sometimes both can fail. Big bubble and visco dissection as well. What can we do? We should move to the traditional DALK, that is manual dissection, layer by layer, peeling off or hydro dissection as you want. I like to go layer by layer, but recently I prefer to use peeling off technique. Here you see we tried the visco dissection, it failed. So keep calm and go deeper and deeper and deeper until you reach the deepest plane. Remember that you should go less than 80 micron for the recipient bed. You should keep calm because otherwise, if you are anxious, it's not possible to finish the surgery. Okay? Look, this I won't speak about this case because this is a stromal scar after an infection with the contact lens in a very young patient. I did this surgery at World Ophthalmology Congress in Barcelona, and this was the pre-op. See the scar. So this is 28 years old. It's almost impossible to have big bubble here because the adhesion of the stroma and the deepest plane is too strong. But anyway, I'm sorry. Anyway, I always try to push some air because you never know really that you won't have big bubble, and air always helps you because you can see how deep you are. So I made a very deep tunnel, as you see here, and I pushed the air, and not big bubble. So I debulked the tissue, and I went looking for a peeling off technique that now is my law. So see, you go deep and deeper in the periphery until you feel that spatula moves very fast, as you can see here. See? And then you try to peel the tissue. If the tissue can be peeled, that means that you are deep enough. You will feel that the spatula moves faster and faster as deep as you are. And see here? So you can try. If the tissue can be peeled, that means that you are deep enough. See? When you have this, it means that you are deep enough. It's amazing. When you do OCT the day after, you will find the recipient bed always less than 30 negative. Okay. Other issues. Donor recipient sites. Always same site. Because if you oversize the donor, you will find 4 or 5 dioptries of myopia. You can use a smaller donor if you want fix in anisometropia, for example, in large keratoconus monolateral. Left eye is good, right eye has -4, -6 cylinder. I suggest you to put smaller donor, 0.25, because you will fix 4 or 5 dioptries of myopia. I like single stitches for many reasons. First of all, because you can manage very well the astigmatism, starting from the 6th month, removing some stitches and controlling the astigmatism. But even if you decide to fix ruptures, then because when you fix a rupture, if you put some stitches that are pushing so much in one area and not too much in another area, the rupture remain open. So you need an homogeneous pressure. And if you find this not good pressure of the stitches the day after, you just remove the strongest and put another one. If you have running sutures, you should make again. Paracentesis. I don't suggest you to do paracentesis before then big bubble. Because if you have big bubble type 2, the bubble can reach your paracentesis and you can break everything. But you should make paracentesis before the visco dissection. Because with the visco dissection, you can only have big bubble type 1, never big bubble. So you need soft eye, and you can control very well pushing of the visco. Another problem, how can we manage big bubble type 2? Don't do paracentesis if you have a big bubble type 2. But please, first open the bubble, because when you go inside in anterior chamber and you have a big bubble type 2, it's very easy that you can perforate. So open the bubble first and then you do paracentesis. Just some tip. Well, Dashman member rupture is too strong. If you want, I can speak. Otherwise, it's probably it's better if we try to do a demonstration of big bubble. Tell me, I'm here to help you. Okay? So let's make the surgery we did. I really do not like this tree-fine because you cannot see anything when you make the trephination. I'm sorry? The original barrel, the single-use barrel, the small one. It's amazing because you can see everything you are making. Let me see the pressure. Oh, it's good. Oh, okay. See? It cannot work because this touch this. See? Yeah. This is the worst. Yeah. Let's try. We do manual. It's too large. Yeah. And this touch with this. Right. Yes, probably. What? Which size is this?
That's the 875.
Okay,
This
okay.
is 80.
It's I don't know if it's deep enough. Do you have a 15 blade?
Yeah.
Yeah. Okay. A little bit used this, huh? Don't you have a new one? Thank you. Yeah. Some water? Water. This? See? The bubble. You can try to enlarge the bubble. No, no possibility more. No more than this. So what it means that dashmate is detachable only there. You don't have to insist, otherwise it will pop. So what can we do now? I need. Do you have how can I say a blade? Yes, the blade that is this way. Sorry. No, because it's too tight here. If you feel the pressure, it's too high. You should be careful to control many things. Yeah. So at this point, you have some disco? No. No problem. I didn't want. Yeah. Okay. Now we should open the bubble. This is Visco. The cannula is not working. We need one cannula. Even this. See?
27 too small.
Too small. Let me try this way. It's not too small. It's that it's not working this. Yeah. Can I put my cannula here now? The cannula we did know. The cannula of Big Bubble. Yeah. Well, the best now is a cataract knife because cataract knife is angulated and you can go inside from bottom to top with a tunnel without losing the air. This is not very good. We will try. Okay? Okay? Now you need paracentesis. scissors. Oh, doesn't cut. But you need good instruments because if it doesn't cut, it's the risk that you break everything is possible. You see? Not cutting.
You normally use the blunt scissor.
I use €10 scissors, but new. When you have iris, you can follow better the periphery because here I cannot see. Yeah. Okay. Water. You should remove visco. Because you do not want visco in the interface. Which kind of visco is this? Sorry? Elon. Elon 5. No, you don't need Elon 5. Regular Elon is okay. It's too strong. So anyway, this is the surgery. As you see, we got the bubble. Anyway, it's not something that you can learn if you do not pay a lot of attention and you will dedicate to this surgery. Anyway, if you are doing PK, try first DALK. You can even convert to PK, but with time, if you are doing PK, your life becomes much better. Because every time that you do a PK in a young patient, when he comes in your office, you are always afraid about rejection. When you do DALK and you see the patient, you start to think other things because he stay okay. That's the difference. Anyway, we even do private courses in Italy, 3 days courses, where you can see pre-op on Monday, op on Tuesday, and post-op on Wednesday. And we do DALK and DMEC. I know that it's far, but if you are doing PK, you should move. For any other question, I'm here. I have a lot of video here. You can see everything you want. Thank you.